Imagery and practice are a way for patients who have lost the ability to move their appendages to relearn how to move their extremities in a safe and effective manner. Patients who have lost their ability to move their upper extremities, especially those of whom are post-stroke victims, can greatly improve their rehabilitation through this manner. Mental imagery requires a multitude of repetitions of cognitively practicing skills in one's mind without physical movements. Mental imagery is incredibly helpful and practical because it does not require expensive equipment, extensive supervision, or the ability to physically move the affected limb. The brain has an ability to respond well to repetitive learning tasks. This is beneficial for the recovery of extremities because mental practice can be used even years after the initial injury. In the case of stroke victims, this is helpful as well because survivors are susceptible to lingering impairments for years after. Mental imagery performed repetitively is shown to activate the same neural areas and musculature as physical practice of the same skills. This allows mental imagery to have great impact on motor learning skills and changes of stroke victims. Mental practice can increase the activity of an upper extremity with paralysis. Mental imagery has the ability to elicit the same cortical changes as physical practice. Imagery has been shown to be best used in conjunction with physical practice of the same skill. Skills that are performed previously will develop quicker because of pre-established motor schema and having the ability to mentally rehearse these skills with ease. Imagery practice allows for a non-invasive strategy to increase motor skills and practice. It has the ability to have the patient perform possibly unsafe movements through imagery rather than physical movements that still allow for motor development growth. Patients can also perform mental imagery in their own. Also, the repetitive task-specific practice, RTP, of imagery practice is a requirement for cortical plasticity and motor changes. In the study Influence of Motor Imagery Training on Gait Rehabilitation in Subacute Stroke, a randomized controlled trial, the researchers wanted to see the effect of imagery training would have on gait training of stroke patients. They chose 44 patients with gait dysfunctions due to strokes. They divided the 44 into two groups, one being the motor imagery group, the other being the muscle relaxation group. The study lasted 6 weeks. Both groups received 2 hours of physical therapy and 1 hour of occupational therapy 5 days a week. This consisted of balance, functional, and muscular training. The motor imagery group was to practice mental practice daily for 30 minutes. They would start with 2 minutes of relaxation. In the first week, they were then seated in a wheelchair with their eyes closed. They were to visualize themselves performing the task of walking and to feel the task of walking as well. In the second week, they were asked to focus on individual gait dysfunctions, things such as forefoot landing, knee hyperextension, hip movement, and stiff knee gait. In the third and fourth weeks, the patients were asked to specifically focus on their step length and walking speed. In the last 2 weeks, gait exercises were rooted in daily tasks. They were asked to view and feel themselves walking in different environments. Alternatively, the muscle relaxation group received muscle relaxation therapy for 30 minutes, 5 days a week. The patients would contract their muscles, then relax their muscles. They were also asked to focus on diaphragmatic breathing. The researchers tested motor imagery ability with a questionnaire and a mental chronometry test. They evaluated gait outcomes by using a 10-meter walk test and a further walking test. The study's results were as followed. Significant difference in mental imagery concerning vividness and kinesthetic imagery. The motor imagery training group had better mental imagery. They also found that the motor imagery group had improved their gait and walking ability more than the muscle relaxation group. In conclusion, mental imagery and mental practice are great efficient processes that can greatly improve the recovery and rehab of stroke victims. Multiple studies have shown that not only can mental practice improve upper extremity recovery, but also lower extremity gait. Mental imagery has the ability to elicit the same cortical changes as physical practice. For best results, mental practice should be used in conjunction with physical practice, such as physical and occupational therapy. The repetitive task-specific practice, RTP, of imagery practice is a requirement for cortical plasticity and motor change. Mental practice is cost-efficient and does not need supervision. Stroke patients often spend large periods of time on their own. This time is perfect for practice mental imagery of specific movements. The process of relearning a specific task can be daunting, especially after such a traumatic incident. Patients have the ability to work independently in their recovery with a proven method that can be beneficial to their psyche and motivation.